So hello and welcome to this cardiology podcast on ischemic heart disease. My name's Ed Wallet.
And I'm Rashmi Patel.
And today we're going to be going through the most basic principles of this really common disease and indeed presentation to hospital.
That's right. We're going to talk about the underlying pathophysiology, what causes ischemic heart disease, the risk factors which predispose to it, clinical features, so what the patient presents with when they come to hospital, and how you diagnose it and manage it. So to understand ischemic heart disease, I think it's really important that you have a good grasp of the underlying pathophysiology, what's actually going on inside the blood vessels. Atherosclerosis causes ischemic heart disease. So what is atherosclerosis? Well, it's a disease process which causes arterial narrowing, and that limits the blood supply to the heart, causing it to become ischemic because of inadequate oxygen supply. And of course, if that persists, then the heart tissue affected by the ischemia will die because it needs oxygen to survive. And so where the heart has some blood supply which is affected by atherosclerosis, the heart might not be able to produce a sufficient output to perfuse the tissues of the body and the lungs.
And that's called heart failure.
Yes, yeah. Exactly. And ischemic heart disease is one of the common causes of heart failure. Indeed. For that reason. So atherosclerosis is a multi-step process which involves, first of all, the formation of fatty streaks. Now, these happen in everyone, regardless of whether they have atherosclerotic disease or ischemic heart disease. It's almost really a natural process. And you get macrophages and oxidized cholesterol forming this layer of fatty streak underneath the endothelium. Now, if it stays like that, then there's no problem at all. However, this can progress because of endothelial damage, for example, as a result of hypertension.
Yep.
And that causes further macrophage activation, platelet deposition, forming this atherosclerotic plaque, which can impinge upon the vessel wall, causing it to narrow. Now, that in itself could cause ischemia simply by not allowing enough blood to reach the heart muscle. However, on top of that, if that atherosclerotic plaque ruptures, that stimulates thrombus formation, and that can then embolize further down the vessel and totally block it off, and that can result in myocardial infarction because of a complete loss of the blood supply to part of the heart.
Yeah, and that's really important, isn't it? Because you've got stenosis on the one hand, causing more of the chronic picture of
angina.
Yeah. While in acute events, that's when you've got a rupture. So that's in your heart attack,
yes,
or unstable
exactly.
angina,
yeah,
etc.
And I think that the key thing here is that you can have one without the other. Someone with a massive MI may not have ever had any angina before in the past,
exactly,
because they've not had significant stenosis.
One of the ways that you can, however, talk about pathogenesis of atherosclerosis, or indeed characterize patients who are likely to have atherosclerotic disease that might be clinically significant, is to talk about various risk factors. Now, the original study that was done for these was called the Framingham study. This was basically a longitudinal cohort study that looked at various risk factors and their importance in the development of atherosclerotic heart disease. Now, basically, you can divide risk factors for atherosclerosis into modifiable and non-modifiable. You can also divide them into high and low risk, but I like modifiable and non-modifiable a little bit more because it's slightly more logical.
That's right. And here we have a list of the risk factors for atherosclerosis. And the reason why it's useful to divide it into modifiable and non-modifiable is, of course, when you've got the patient in front of you, you can advise about reducing the risk of the modifiable ones.
Yeah,
so in everyone, you'd want to try and stop them from smoking if they smoke, and normalize their blood pressure if they've got hypertension, treat them with statins if they have hypercholesterolemia, and good glycemic control, they are diabetic.
Absolutely.
But of course, the non-modifiable risk factors are important as well in thinking who's at risk. Seeing a patient in front of you who's old and has a family history of ischemic heart disease raises your suspicion.
Yeah, and particularly a family history where relatives have been affected under the age of 55.
Yes, where they've been young. Yeah.
Okay, so how does ischemic heart disease manifest? This is a really important slide. There are two basic clinical manifestations, or two basic sets of clinical manifestations. The first one is chronic stable angina. Now, that's what we're talking about, the stenotic phenomenon, the clinical result of the stenotic phenomenon. Acute coronary syndrome is a kind of catch-all phrase, which we'll talk a little bit more about. But basically, that includes all the acute things. So that's basically three things you need to remember. That's unstable angina, non-ST elevation myocardial infarction, that's often called an NSTEMI, and ST elevation myocardial infarction, that's a STEMI, and that's your traditional heart attack.
That's right. Okay, so we'll start off with the chronic stable angina. And what is angina? Well, it's simply chest pain which happens on exertion, which is relieved by rest and nitrates, for example, GTN spray, which often patients will carry around with them. And as we said before, it's caused by atherosclerosis. Occasionally, patients without atherosclerosis can get angina as a result of vasospasm, often also called Prince-Metal variant angina, but that's quite rare. When you actually see the patient, they may not actually have anything to find on examination, and they may just tell you on the history they get chest pain, but their examination of the cardiovascular system will be completely normal. Similarly, if you do an ECG, it might be completely normal, or it could show non-specific changes in the ST segments. However, if they've also had a previous MI, whether they've known to have it or not, that might manifest with Q waves.
And indeed, sometimes MIs in certain groups of patients can be totally asymptomatic.
That's right.
It's important to realise
diabetic, for example.
Diabetic, for example, who have degrees of neuropathy, may not get symptoms if they have MIs, and also the elderly, so particularly the elderly population, they can also have silent MIs.
So I think one way to try and establish whether the cause of their chest pain is because of ischemia is to do an exercise tolerance test, because that stresses the heart.
Exactly.
And if you've got a poor blood supply, then you might begin to see these ischemic changes on the ECG, for example, ST depression. And if that happens, then you can then go on to do an angiogram to see if there really is any stenosis in any of the coronary vessels, and then you could treat that with angioplasty.
Yeah, that's really important. That idea that angiography is both a diagnostic investigation, but can also be used as a therapeutic tool.
Yeah, that's
as well.
right. Yeah. Okay. Acute coronary syndrome. Now, what this really it's not really a diagnosis. It doesn't tell you what's wrong with the patient, but it tells you how they're presenting, and it's really quite simple. The patient presents quite unwell with chest pain, shortness of breath. They might also be nauseated and vomiting and sweating.
And that's really because of, it's called diaphoresis, isn't it? That's because of excess sympathetic
drive.
Sympathetic drive that's associated with this acute event.
Yeah. And what the underlying diagnosis really depends on whether the heart muscle has been damaged. And I'll come on to how you can work that out in a moment. And as we mentioned before, this idea of the atherosclerotic plaque rupturing and forming an embolus, that's often the cause of acute coronary syndrome, because this embolus completely blocks off the vessel.
Yep.
Right, so this is how you can work out what's actually going on inside the heart. Cardiac enzymes, in particular troponin or troponin.
There are lots that have been described, aren't there?
That's right. So creatine kinase and several others. But troponin is quite helpful because it can be measured specifically for the cardiac isotype. And using this test, you can work out if someone presenting with acute coronary syndrome has had any underlying heart damage. However, it's important to remember that the test won't tell you what's caused that damage. It will only tell you that part of the heart muscle is dead. But most often that will be because of ischemic heart disease.
Yeah.
Okay, now this graph illustrates the different types of cardiac enzymes which are released following an infarct. And you can see in the blue outline the troponin with and without reperfusion. And if you notice, you can see that the peak of the troponin happens quite late as opposed to CK. So when you test the troponin, ideally you want to wait 12 hours after the start of the patient's symptoms.
That's the key number of hours, 12 hours, yeah.
Right. Unstable angina. So this is the first type of acute coronary syndrome. And this can present in a number of ways. It could be chest pain at rest, or it could be acute on chronic angina. So the patient has already had stable angina, but it has now got to a stage where the patient is beginning to get worsening angina and beginning to get pain at rest. Or recurrence of chest pain having had a previous MI.
Yeah.
And when you look at the investigations, if you look at the ECG, often you'll see signs of ischemia, ST depression. The key thing with unstable angina is that the cardiac troponin will be normal. It won't be raised, and that indicates there has been no irreversible damage to the myocardium as a result of the ischemic event. And you can then go on to do further tests, for example, echo and exercise tolerance tests to demonstrate that the patient has cardiac ischemia, and if there's a positive AS or stable angina, you'd want to do an angiography as well.
Exactly. So in the setting of non-ST elevation myocardial infarction, that's our second acute coronary syndrome, the features are very much as per unstable angina, which Rashmi's already described. And indeed, the ECG often shows ischemic changes such as T-wave inversion or ST segment depression. However, the cardiac enzymes are the characteristic thing to look at here. While they're not raised in unstable angina, in non-ST elevation myocardial infarction, you get a rise in the troponin T or I after your typical 12 hours.
That's right.
Yeah. And then you can go on, as before, to look with echo at myocardial function. And angiography here is very important, as you want to identify and confirm the presence of atherosclerotic or ischemic heart disease, and indeed go on to treat it.
And one thing to also note is that because you know the underlying diagnosis, you wouldn't need to do an exercise tolerance test because you've already demonstrated the patient has had an infarct.
Exactly.
So, ST elevation myocardial infarction. Now, this is the classical picture of someone presenting with an MI. The clinical features are the same, although, as we've mentioned before, some patients don't have
elderly,
any
diabetic,
pain at all.
Exactly.
And the ECG shows characteristic ST elevation, which you can see here on the next slide. That this one demonstrates an inferior myocardial infarction. The ST segments in leads 2, 3, and AVF are elevated.
Yeah, and you should definitely try and picture this, look at this ECG.
Yeah, this is classical ECG pattern, which as soon as you see, you'll be able to recognize.
Exactly.
Right. Now, how do you manage acute coronary syndrome? I think the point here to make is that it doesn't matter what the actual diagnosis is, because you won't actually be able to know the diagnosis until after you've had the investigations, the troponin. So you manage anyone with suspected myocardial infarction or acute coronary syndrome the same way.
Yes.
And that way is, first of all, resuscitate the patient.
Always resuscitate the patient,
Check their airway, breathing and circulation. Give them high-flow oxygen. Aspirin and clopidogrel, so antiplatelet agents, which have been shown to dramatically reduce the mortality as a result of myocardial infarction. Heparin, sublingual nitrates, for example, GTN, and that helps dilate the vessels.
And also helps relieve symptoms as well.
That's right, yeah. And morphine and metoclopramide as an antiemetic. Now, morphine has several effects. First of all, obviously, as an analgesic to reduce the pain. And it also has an effect on the circulation, again, a vasodilation of the blood vessels to help improve the blood supply. Now, the key thing here is then when you look at the ECG, if you see ST elevation, the patient needs urgent coronary intervention, and ideally they should be transferred to a tertiary centre where they can have immediate percutaneous coronary intervention, in other words, angioplasty, and a stent in order to relieve the obstruction to the affected blood vessel. However, where this isn't available, you can also thrombolyse a patient. For example, in rural areas where it can be difficult to get a patient quickly to a tertiary centre.
Yeah, indeed.
Now, the ongoing management, if the patient has not had an ST elevation MI, it is looking, again, to try and work out the underlying diagnosis. And as we mentioned before, the cardiac enzymes are key here to distinguish between unstable and unstable angina and a non-ST elevation MI. And as we said before, there's no need to do the exercise tolerance test if you've got the positive enzymes, because you already know them.
No, in the presence of that typical history, together with the rise in troponin T or I, you know what the
it's very, very likely that they've had an infarct. Yeah. And then you would go on to treat with these antiplatelet agents, aspirin, clopidogrel, and then ACE inhibitors, statins, and then if the patient has got a normal blood pressure and they're not bradycardic, you can also consider a beta blocker. And all of these drugs have been shown to reduce mortality following a myocardial infarction.
Exactly. Okay, so in summary, in this brief podcast, we've looked at the most important mechanism underlying ischemic heart disease, that's atherosclerosis. We've talked about how atherosclerosis results in vessel stenosis, and indeed it can acutely cause occlusion of vessels due to plaque rupture and thromboembolus. Vessel stenosis basically corresponds to your chronic stable angina, but thromboembolus corresponds to your acute coronary syndromes.
That's right. We've also talked about the risk factors for ischemic heart disease, and particularly breaking them down into the modifiable and non-modifiable. And I should stress that in all patients, regardless of whether they've had any kind of myocardial infarction, you always want to try and reduce the modifiable risk factors. So smoking, hypertension, and hypercholesterolemia, good glycemic control, and diabetes, as that's going to have an impact on their future cardiovascular risk, regardless of whether they've had an MI or not.
Exactly. Yeah. And then lastly, we've talked in detail about the acute coronary syndrome. In particular, we talked about unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. In terms of the key differences, you should take away that they all can present in roughly the same way. So with sudden onset of chest pain, worsening of angina, together with diaphoresis, so that's overactive sympathetic drive.
Right, yeah.
The thing that distinguishes them, however, is basically the ECG changes and the troponin. So in unstable angina, you'll have ischemic ECG changes, but with a normal 12-hour troponin. In non-ST elevation myocardial infarction, you'll have a raised troponin with some ECG changes, but not importantly ST elevation. If you see ST elevation with the characteristic history, then that patient needs urgent transfer for percutaneous coronary interventions such as angioplasty and stenting.
That's right, yeah.
And if that's not available, then you can consider thrombolysis.
Absolutely.
So thanks very much for listening. We'll see you soon.
Thank you.
Bye.